Welcome back to The Explainer. Today, we are jumping into a real high-stakes medical emergency, acute kidney injury, or AKI for short. We're going to break down what happens, those critical minute-by-minute decisions when a person's kidneys just stop. All right, so let's set the scene. A patient's kidneys have just failed. Now, what do you think doctors do first? You might be surprised. It's actually not about fixing the kidney itself. The real, immediate danger is somewhere else entirely. And believe me, the clock is ticking. So the first step, it's all about crisis control. Think about it. When the kidneys fail, they can't do their main job, filtering the blood. And that unleashes this cascade of life-threatening problems. The body's entire chemistry just goes completely haywire. And that's the key takeaway right here. The initial goal isn't to heal the kidney. It's to stop the body from shutting down around it. Doctors are basically firefighters at this point. They're not worried about rebuilding the house. They're desperately trying to put out all the little fires that have started everywhere else, threatening to bring the whole system crashing down. Okay, so what does this first-line defense actually look like in practice? Well, this is the rapid response phase. It's where the medical team rolls out their toolkit to tackle the most dangerous chemical imbalances one by one. And problem number one, the big one, is hyperkalemia. That's just a fancy way of saying dangerously high potassium. And of all the things that go wrong, this one is often the most immediately fatal. Why? Because it can literally stop the heart. So what's the fix? Well, it's a really cool multi-pronged attack. First, they give calcium gluconate. Think of this as a shield for the heart. It doesn't lower the potassium, but it protects the heart muscle from its dangerous effects. At the very same time, they'll start an insulin drip and use salbutamol. These two actually push the potassium out of the blood and into the cells, basically hiding it where it can't do any harm. And of course, they'll stop any drugs the patient is on, like certain ACE inhibitors, that might be making the whole situation worse. All right, next up on the problem list is hyperphosphatemia, or high phosphate. Now, this one isn't quite as immediately terrifying as the high potassium, but if you let it go, it can cause some really serious long-term damage to bones and blood vessels. And the fix for this is pretty straightforward. It's a two-part plan. First, you restrict phosphate in their diet. Easy enough. Second, you give them these things called phosphate binders right with their meals, drugs like calcium acetate or sevelamer. What they do is pretty clever. They basically grab onto the phosphate from the food while it's still in the gut and stop it from getting absorbed into the blood in the first place. Okay, another huge job for our kidneys is getting rid of acid. So you can guess what happens when they fail, right? Yep, that acid starts to build up in the blood. This leads to a really dangerous state called metabolic acidosis, and it can mess with how pretty much every organ in the body functions. But for severe acidosis, there's a pretty direct fix. You've got too much acid, so what do? You add a base. Doctors give a dose of sodium bicarbonate to rebalance the body's pH. It works like a buffer, neutralizing all that excess acid and bringing things back into a safer range. And last but definitely not least, we have a major problem with fluid overload. I mean, it makes sense, right? If the kidneys aren't making urine, all that fluid has to go somewhere. It builds up in the body, and when it backs up into the lungs, that's called pulmonary edema, it becomes an absolute emergency. The patient literally can't breathe. And the usual fix, diuretics, often don't work because the kidneys are just too damaged to respond. So you're doing all this stuff, but what happens when it's not enough? What if the potassium level just won't come down, or the fluid keeps building up in the lungs? Well, that's the tipping point. That's when you know it's time to call for some serious backup. And that backup has a name, renal replacement therapy, or RRT. You probably know it by its more common name, dialysis. This is where the machines come in. A dialysis machine is, for all intents and purposes, a temporary, artificial kidney that takes over the job of cleaning the blood. But how do doctors decide exactly when to pull the trigger on dialysis? In these high-pressure moments, they need a clear guide. And they have one, a really simple and memorable mnemonic, AEIOU. It's pretty brilliant, actually. Each letter stands for a situation where dialysis is a must. So you've got A for acidosis, that's just not getting better with bicarbonate. E for electrolyte problems, like that super high potassium that just won't budge. I is for certain intoxications, like poisoning from stuff like methanol. O stands for fluid overload, especially in the lungs when diuretics aren't working. And U is for uremia. That's when the toxins build up so much, they start causing major problems like confusion or even inflammation of the heart. And let's zoom in on that U for a second. Some things are just absolute, non-negotiable reasons to start dialysis. The big one is something called uremic pericarditis. That's inflammation of the sac around the heart caused by all those toxins. If a doctor sees that, it is an absolute indication for dialysis. No questions asked. You start immediately. All right, so the call has been made. The patient needs dialysis. But here's the thing, it's not a one-size-fits-all solution. There are basically two main paths you can take, and which one you choose really depends on how sick and unstable the patient is. The best way to think about it is sprinter versus marathoner. First, you've got intermittent hemodialysis. That's the sprinter. It's a quick, intense 3 or 4 hour session. It yanks all the toxins and extra fluid out really fast, mostly using a process called diffusion. It's super effective, but it can be rough on the body and cause blood pressure to drop. So this is for patients who are more stable. Then you have the marathoner, continuous therapy. This is a slow and steady 24-hour treatment. It works more gently, using both diffusion and another process called convection. Because it's so much gentler, it's the go-to for the most critically ill, unstable patients you'd find in the ICU. So you can see how all these powerful tools, the drugs, the machines, they're all about managing the crisis. They are quite literally a bridge to survival. But they're a bridge, not the final destination. And that brings us to the big question, right? With all this life support in place, what does recovery from AKI actually look like? What happens next?